Jason is going to talk about drug-eluting stents for non-coronary applications and really talk about the problem of restenosis and maintaining patency.
Thank you, Dave. I'm going to try to harvest some of that energy that we had in the last presentation and move us into a related topic on drug elution, on stents. I mean, this is clearly one of the most innovative and disruptive technologies of the last decade, putting a drug on a stent and influencing clinical outcomes. We have a tremendous amount of information related to this in the coronary circulation, and the question is, how is this translated to the peripheral circulation? So whereas Arnold Schwarzenegger's legacy may not have been the reduction of the California state deficit, certainly his legacy will include several of his famous lines in cinema. So there are things that come back, and within the vascular beds that we treat, there are beds in which restenosis is significant, and drug elution might seem to be an attractive solution. And the question is, what is the data, and how do we look at this problem? Now, translating things from the coronary to the peripheral circulation is not trivial. Peripheral vessels are not the coronary arteries. Having said that, a lot of our understanding comes from the coronary arteries. These are the currently FDA-approved stents in the United States. We have paclitaxel eluting stents, and we have rapamycin or related rapamycin eluting stents. Now, paclitaxel is used for chemotherapy. It's isolated from the Pacific yew tree. It binds to and stabilizes microtubules and prevents cell mitosis and division, and also has some other effects on inflammation and sort of attenuating cell migration. The other large family of drugs are the limus drugs. These are derived from rapamycin, which was originally named after the Rapa Nui Indian tribe on Easter Island, where this bacteria was isolated. In any case, these rapamycin drugs halt the G1 to S cell cycle transition and essentially stop cell regulation. So both of these are anti-proliferative agents. Clinically, we know that this family of drugs seems to have more of an effect on preventing the growth of scar tissue than paclitaxel, although both drugs have been shown to have clinically important endpoints. So moving on to the renal arteries, there's really only one randomized trial so far published that looks at the potential benefit of a drug-eluting stent in renal arteries. So this was bare metal stenting versus sirolimus-coated stenting in 5 and 6 millimeter Pallmas Genesis stents. And the primary endpoint, which was a 6-month quantitative vessel analysis, was non-significant for all variables shown. And I would point out that the in-stent restenosis rate for a bare metal stent was quite low at 14%, lower in sirolimus at 6.7, but essentially not significant. Now, these were somewhat larger renal arteries, certainly not the largest, but it has been proposed that drug elution may be more useful in subsets of renal intervention. So smaller renal arteries, perhaps a single functioning renal artery, smaller accessory renal arteries, or for in-stent restenosis. And there's a recent publication from the Mayo Group that looked at the use of drug-eluting stents in renal arteries that were less than 4 millimeters. And you see here the dotted line is a bare metal stent patency at 15 months, and the solid line is the drug-eluting. So the average vessel size was 3.4 millimeters for the drug-eluting stent. Despite the smaller vessel size, there was a higher primary patency. Now, was the creatinine better? Was hypertension better? We don't know that from this report. SFA intervention is kind of the holy grail for drug elution because there are so many factors that influence patency in the SFA. Not only the growth of scar tissue or neointima, but the many other factors that result in adverse outcomes in this hostile environment. As we have just heard, stents are known to be, in general, more effective than standalone angioplasty for the treatment of medium length or longer length femoral popliteal lesions, but can we improve upon this with drug elution? Now, there have been 3 companies that have taken on this charge, and They're listed here, so Johnson & Johnson, Abbott, and Cook. These are the drugs that were used, and we'll go more into these randomized clinical trials to follow. But this is a fascinating evolution here in kind of our understanding of some of the platforms, the way the drug is applied, and I think importantly, as we'll see in the Zilver PDX trial, the study design, how that evolved, understanding how the other trials performed previous, kind of before. So the first trial was this Scirocco trial, which looked at the sirolimus-eluting smart stent in very just limited stent selection, either 6 or 7 millimeters in diameter and a length of 8 centimeters. We thought we knew what worked in the coronaries, so we were going to put it on a peripheral stent, the same concentration. And if you pulled the data from Scirocco 1 and 2 using the longer eluting formula, it was negative. There was no sustained reduction or change in clinical events at 24 months. So after that effort, perhaps disappointing to many, that sort of investigation by Johnson & Johnson Cordis was discontinued. And the story was left unpursued until the more recent attempt by Abbott in their STRIDES trial. So they had a more contemporary stent design, the Dynalink stent, and a more contemporary drug, everolimus, that was applied with a polymer that showed success in the coronary circulation with a triaxial stent delivery system. And the hypothesis was that a longer elution profile, that the drug is around longer, would help reduce restenosis and ensure a more durable response. But unfortunately, and this is the trial design, multiple centers, a little more lesion complexity. Whereas at 6 months, there was a favorable binary in-stent restenosis rate of 14%, so patency of 86%. This did not hold up over time, and in fact, in comparison with historical SFA bare metals trials was not significantly different because there was this deterioration of efficacy over time. And this is the conundrum. Why does this happen? How do we prevent this? And drug elution is not the only answer. So now we have the most recent data set, which is the Cook-Zilver PTX. This data has not been published, has been presented publicly several times. And the theory here is that they used a spray-on paclitaxel. There's no polymer or binder. Polymers can cause chronic inflammation and make the problem worse. The polymerless application is actually very effective. The drug stays on its sheath within the delivery system, and it actually sticks around in the tissue for up to 2 months. So you have no polymer and a more durable tissue retention. I can't say that I fully understand all this trial design myself, but whoever designed it may have been, at least partly ingenious, because they designed many bifurcation points here, and I think many opportunities for the Zilver PTX stent to look excellent. And the first bifurcation point would be, is a drug-eluting stent better than PTA? Well, I think we already know that a bare metal stent is better than PTA, so this is a win-win bifurcation here. Once you have PTA, then they defined a failed PTA as a greater than 30% stenosis or a translesional gradient of greater than 5 millimeters of mercury. And I'm not expert enough to know if these are valid or have been proven, but this was these were the guidelines given, and then if you failed, then you had the final sort of money, which was that does bare metal perform any different than drug elution? So in analyzing this, we have to understand what patients were excluded. Again, sort of medium to longer length lesions, less than or equal to 14 centimeters. Rutherford classification greater than 2. They did look at sort of a clinical endpoint, which was death, freedom from death, amputation. They looked at a patency endpoint either by duplex or angiography. And they looked at a 5-year follow-up. And we currently have 2-year follow-up that's been reported. These were the baseline lesion characteristics. As Dr. Roque Singh pointed out, the stenosed lesion length is fairly short, about 5.5 centimeters. The diameter stenosis, 70 to 80%, and about a quarter of the lesions were total occlusions. So if you looked at the sort of clinical endpoint, which is freedom from death, amputation, or re-intervention or worsening Rutherford class, the Zilver stent seemed to perform better than PTA. In fact, it did at 24 months. And this is very encouraging in terms of our clinical, our need for clinical assessment of the patient. In terms of stent fracture, which had been a little bit of an Achilles heel in the Scirocco trials, was then overcome in the Abbott trials. We have here also a stent which has an extremely low fracture rate at 12 months. So stent design has improved to the point where that does not seem to be a factor in directing outcomes in these trials. If you looked at the sort of duplex, and this is kind of a short straw man here with the PSVR less than 2, and you looked at the black, gray, and red boxes, here are the patency rates by duplex at 12 months for either PTA, successful PTA, or Zilver PTX. So the drug-eluting stent performed better than PTA, which is encouraging but perhaps not surprising. This was durable at 24 months, and I have yet to understand exactly how these numbers are derived in terms of follow-up, because it's not the total cohort, and I think that may come out in a publication. But the bottom line here is that a drug-eluting stent performs better than PTA in terms of duplex criteria and also some of the clinical endpoints that they provided. Now, what about what we really want to know, which is, did it perform better than a bare metal stent, which is the final bifurcation here. And the black is bare metal, the red is drug-eluting, and at 12 months by duplex, the bare metal stent performed less well than the drug-eluting stent, which is great news. We have here a technology which improves patency over a bare metal stent, and this was consistent at 24 months with a 50% reduction in the relative restenosis rate at 24 months by duplex. So that was a fairly controlled trial with a smaller lesion length, highly regulated. How does this perform in a larger cohort? We do have some data from 30 sites in Europe, Canada, and Korea, the Zilver PTX registry, with now 900 lesions treated with an average lesion length here of 10 centimeters. 22% of those were greater than 15 centimeters, and about 38% were chronic total occlusions, 1.9 stents. Very low stent fracture rate at 12 months. And at least from the data that we have from this real-world experience, is that the freedom from TLR, clinical endpoint, at 24 months was 84%. And then the primary patency with the PSVR of less than 2.5 was 86%. So favorable, but how that compares with a non-drug-eluting stent, and it's not a randomized comparison, but at least it's some confirmatory evidence that this therapy can be safe, it can be applied, and result in quite reasonable outcomes. So the conclusions that I draw, and we can certainly discuss this from the Zilver PTX randomized trial, is that Zilver PTX is certainly better than PTA, not a big surprise. The primary Zilver PTX patency rate's about 75%. And the provisional Zilver PTX patency rate is higher than provisional bare metal stenting. And I don't, I think a lot of this is to be explained, and someone please explain it to me. I still don't understand exactly why a provisional patency rate would be higher than a primary patency rate. But in any case, both were superior either to PTA or bare metal stenting. And the registry data does show at 12 months that 86% of patients had primary patency. So this is an exciting development in this field, how we will interpret and finally digest this data, and to how much benefit it has over bare metal stent is to be seen. I think we still have a lot of work to do on the proper dose, the release kinetics, the use of polymers shown in the lower right, which can fracture and cause chronic inflammation. Stent fracture problem seems to have been largely solved, but perhaps not in very long lesions. And then ultimately, what is the cost-benefit ratio of these technologies, and will our government agree to either approve A or B, pay for them? Just a word on infrapopliteal drug-eluting stents. As Krishna had said, a lot of the data is from single centers. They are for very focal infrapopliteal lesions. Based on that data, both the Cypher and Xience V stents have CE mark approval for below-the-knee intervention. And there are basically a benefit in terms of patency, angiographic or otherwise, in terms of DES versus BMS, but less convincing data in terms of freedom from amputation or other clinical endpoints. I had always thought that stent fracture or crush in the below the knee would be an issue, but that appears to be a very rare event. So I think that at least for shorter lesions, you can use stents in that area. We heard about the Achilles trial, which was one randomized drug-eluting. This is the Destiny trial. The Achilles trial looked at the Cypher stent. This looks at the Abbott Xience V stent versus the Multi-Link Vision bare metal stent in the lower limb. 5 European centers, very short lesions, less than or equal to 40 millimeters. The endpoint included a binary in-stent restenosis by angiography, so no duplex here, and any target lesion revascularization performed within 12 months. Not unsurprisingly, the drug-eluting stent resulted in better primary patency at a year. It resulted in less need for reintervention on that lesion, but didn't really result in any clinical difference in terms of limb salvage rate. 98.7% versus 97%, non-significant p-value. So clearly, we do a good job of reducing neointimal formation, but no difference in clinical outcome. Now, the final sort of frontier, and I think this is a very exciting new area for drug-eluting stents. If you look in the literature, pretty much anywhere anybody can get a stent, they've probably put a drug-eluting stent, and you can find case reports of a drug-eluting stent in just about every artery in the body, but not this artery. And so I want to just briefly touch on some research that we have been involved here at UC Davis. Krishna is also a co-principal investigator for this trial, which is the Zen trial, and it deals with the patients that we see every day in our clinic. Maybe we don't identify these patients, but they are in our practice. And there are 30 million men with ED and over 300 million men worldwide. And the time for talking about this problem has come. I mean, if Bob Dole can get up and talk about it, I think we can with our patients. Our patients have erectile dysfunction because the risk factors for erectile dysfunction are exactly the same as those for atherosclerosis, and they result in endothelial dysfunction. Up to 70% of men with known coronary disease have ED. It's a novel risk factor for the development of overt cardiovascular events. So if you have a middle-aged man who smokes who has ED, probably should think about lipid-lowering therapies or other cardiovascular risk factor management. Having said that, we still don't, as a profession, do a very good job of screening these patients. And in terms of this whole size hypothesis, this is an interesting thing. This was purported by Montorsi et al. in AJC. But if you look at the different kind of vessels in the body, here's the femoral SFA, here's the internal carotid, coronary artery 3 to 4 millimeters, penile artery 1 to 2. There's another artery in here, the pudendal artery, which is about 2 to 3. If you postulate that atherosclerosis affects all vascular beds at a more or a relatively constant rate, you would expect that the smaller arteries would be affected first. And that may be one of the reasons why patients develop ED before they actually develop overt coronary or other vascular disease. And we did some pilot work to show that the two main arteries in the pelvis which supply the penis are actually about the same size as a coronary artery. They're 2.7 millimeters and therefore seem to be a reasonable target for currently available coronary drug-eluting stents. Here's the two paired arteries. There's one on the left and one on the right. These are called the internal pudendal artery, IPA. It's a terminal branch of the internal iliac artery, which exits the pelvis and then enters the base of the penis here, and it bifurcates into two arteries, a dorsal artery and a cavernosal artery. For normal erectile function, you have normal blood flow, which results in normal erectile function. If you have an atherosclerotic lesion, in some young men there's traumatic lesions or vessel injury, but in this case, an atherosclerotic lesion. There's poor inflow and therefore erectile dysfunction. So we've been involved in this so-called ZEN trial, which is the use of zolurolumab eluting peripheral stent system for the treatment of ED in men who've already tried Viagra or other PDE5 inhibitors and have had a suboptimal response. And this is a prospective single-arm trial with endpoints of primarily safety and secondarily efficacy. This is really mostly a safety and feasibility trial, enrolling up to 50 patients. And the sort of main hypothesis here is that the deployment of a drug-eluting stent in the internal pudendal artery in patients with stenoses amenable to this technique would therefore have, would be safe, it would be feasible, and then potentially effective as well. So just to show you how this works briefly, this is a case of a patient with erectile dysfunction as part of the trial after fairly extensive duplex screening, which I'm not going to get into today. We do an angiogram which shows us some of the distal vessels that supply the penis. So here is a selective arteriogram of the right internal pudendal artery, which comes here, and you see a focal stenosis here, and then it terminates here at the base of the penis. These are more superficial branches which go either to the scrotum or the perineum. And this patient was treated with a drug-eluting stent. We've learned a lot about this vessel. In this particular case, there was some adventitial extravasation, unlike you would see in an SFA stent at times, which was of no clinical consequence. And in follow-up angiography at 6 months, we saw good vessel patency with minimal restenosis, as you would expect with the drug-eluting stent. Here you see the penile vessels. Here's the dorsal artery, the pointer's running out, and then also the cavernosal artery. We also do a hip flexion maneuver on all these patients, and we document whether there's any deformation in the stent or not. In this patient, there is none with hip flexion. So in concluding my talk, early, which I think is good, we will say that drug-eluting stents are a promising therapy, but certainly not a panacea. Peripheral drug-eluting stents have had improved success, particularly with the recent Zilver PTX trial, and there's been documented clinical success in the infrapopliteal bed, and I think that we will continue to innovate and have novel applications for this technology. Thanks very much. An attractive solution. And the question is, what is the data and how do we look at this problem? Now, translating things from the coronary to the peripheral circulation is not trivial. Peripheral vessels are not the coronary arteries. Having said that, a lot of our understanding comes from the coronary arteries. These are the currently FDA-approved stents in the United States. We have paclitaxel eluting stents, and we have rapamycin. Thank you, Dave. I'm going to try to harvest some of that energy that we had in the last presentation and move us into a related topic on drug-elution, on stents. I mean, this is clearly one of the most innovative and disruptive technologies of the last decade, putting a drug on a stent and influencing clinical outcomes. We have a tremendous amount of information related to this in the coronary circulation, and the question is, how is
Jason is going to talk about drug-eluting stents for non-coronary applications and really talk about the problem of restenosis and maintaining patency.
This translated to the peripheral circulation. So whereas Arnold Schwarzenegger's legacy may not have been the reduction of the California state deficit, certainly his legacy will include several of his famous lines in cinema. So there are things that come back, and within the vascular beds that we treat, there are beds in which restenosis is significant and drug-elution might seem to be, or related rapamycin-eluting stents. Now, paclitaxel is used for chemotherapy. It's isolated from the Pacific yew tree. It binds to and stabilizes microtubules and prevents cell mitosis and division, and also has some other effects on inflammation and sort of attenuating cell migration. The other large family of drugs are the limus drugs.